everybody. Welcome to Congenital Heart Academy. We are very happy to have all of you with us today, and we are happy to have whoever is going to connect later on our YouTube channel and is going to watch this amazing meeting. I want to thank Dr. Rima for put all of these experts together, and Norman Silverman for always being here with us. Thank you for all the speakers of today. Congenital Heart Academy really appreciates every effort that everybody is putting to have this amazing meeting today. I just want to remind you to please follow us on social media and subscribe to our YouTube channel. We have more than 100 webinars recorded and for free on YouTube. You can check anytime and share with your colleagues. And if you find this specific webinar interesting today, please share the link of YouTube with your colleagues, with your team. I'm sure everybody's going to benefit from this meeting. Tomorrow, we have the first session of Dr. Anderson of the year. He's going to revisit the basics of the cardiac development in a very interesting way. I advise all of you to join us tomorrow. A quick reminder, we are going to have a special issue of the Children's. It's an open access journal, very good impact factor, and it's going to be only about the advances of pediatric cardiac surgery. The guest editors are Sasha and Luciana Fonseca. So please send your research, and this is going to be a very special edition. So please scan this QR code. It's going to take you to the website of the World Congress, and I hope to see you all there. Now with you, Dr. Rima, who is going to chair and introduce this amazing webinar that we're going to have today. Thank you all, and please type your questions on the Q&A chat box, and I'm sure the speakers are going to be more than happy to answer all of your questions. Thank you, guys.
Thank you, Grace, and I'm sure the World Congress is going to be very, very interesting for people from all over the world, just the world. And the abstract, I think submission line is open, correct, Grace?
Yes, it is. So if you need a quick response, if you submit until 10th of February, you are going to be able to be evaluated on the first ones. If you need it for travel issue, so if you need to have your abstract accepted so far, but the final date is going to be early May, late April, early May.
Thank you, Grace. I just want to welcome everyone. Happy New 2023. This is our first fetal session in the 2023, and it's actually the 24th episode of our fetal series. I'd like to thank the Congenital Heart Academy for giving us a chance to share the knowledge. I'd like to especially thanks to Dr. Silverman for being always available for us. And another special thanks to all the speakers from all over the world who really cared to share the knowledge free of charge and share their time. We're going to have 3 talks, and the first speaker is Dr. Sally Ann Kleur, and she's currently based in Amsterdam, and she is a trained interventional pediatric cardiologist and a pediatrician with special interest in fetal cardiology. And she does a lot of work in academics and fetal arrhythmias in children and fetal arrhythmias. And she's an active member of the fetal cardiology group in the AAPC group. Sally, she's going to talk to us about fetal cardiac function, and the talk is going to be 20 to 25 minutes. Sally, please proceed.
Right. Thank you very much for that nice introduction. I've been asked to speak to you about fetal cardiac function, and I will do my best to do that. Before we get into evaluation of fetal cardiac function, it's important that we have some idea of the basic physiology of the fetus. Fetal cardiac function is different. Why is it different? The fetus has a reduced systolic function because there are less contractile elements. The mitochondria and the sarcoplasmic reticula are less organized and developed, so active contraction is less effective. The diastolic function is reduced, the ventricles are stiffer, and we see non-compliant ventricular filling in early and mid-gestation. There's a limited range of heart rate that the fetus is able to change in order to compensate for changes in cardiac output. So there is a reduced adrenergic stimulation response, and the heart is developing. The blood circulation is a parallel circulation, which is different to after the birth, and this is because of 3 essential shunts: the ductus venosus, the foramen ovale, and the arterial duct. The right ventricle is responsible for the majority of the cardiac output of the fetus, between 60 and 65%. Is pumped by the right ventricle and the rest by the left ventricle. Both ventricles work together to provide the total cardiac output. 45% of this is directed to the placental circulation, 10 to 20% to the pulmonary circulation. It decreases a little bit in the late gestation, and the rest goes to the upper body, coronary arteries, and brain. The placenta is has a low vascular resistance, so we have a situation with low systemic vascular resistance, but high pulmonary vascular resistance because the lungs are filled with fluid. The right and left ventricular pressures are approximately equal, as are the right and the left atrial pressures, and the atrial pressures are low. So in the fetus, the right ventricle is a systemic ventricle, and this is important to be aware of. The Frank-Starling curve is pushed to upper limits, and so we see the curve of the fetus on the right. And the stroke volume of the fetus is dependent on preload and contractility, and they have a positive effect. And afterload has a negative effect on your stroke volume. And your stroke volume times your heart rate gives you your cardiac output. I will skip that for now. When a heart failure occurs, the fetus is able to preserve systolic function pretty much until imminent collapse. The first thing that we see is that the right ventricle fails. You get an increase in your right ventricular end diastolic pressure, tricuspid regurgitation, elevation of your right atrial pressure and your central venous pressure, and then we get fluid collections in the pericardial, pleural, and abdominal cavities. Hydrops develops, get placental edema, and the final result is fetal hypoxemia. There are several causes of cardiac failure, but it really doesn't matter which is the cause because the mechanism is the same. You get elevation of your right ventricular pressure. You get increased lymphatic production, congested livers, congested placenta, reduced protein production, neurohormonal activation, and hypoxia and hydrops. So how can we assess the fetal cardiac function? Now, I know that a lot of people that make use of the videos of this academy are in places where there's not a lot of fancy technology available. So I'm going to be giving you some basic things in first. I tell you basic things at first. Look at the size of the heart. Is it big? Has it got a normal size? Is the form of the heart correct? Fetuses, for example, with intrauterine growth retardation tend to have more globular, thicker hearts. So the shape of the heart is important. We can do a shortening fraction using M mode, like we do on a post-natal baby. But the form of the right ventricle is not really conducive to accurate measurement using the shortening fraction. Measurements are small and it's difficult sometimes to get your angle exactly at 90 degrees. So an easier method is to use the TAPSA. And then we can look in the longitudinal fiber orientation of the right ventricle and get an idea of systolic function. The right ventricle is not ellipsoid, and so the Simpson rule is not suitable. So we have to think of other ways in order to assess the volume of the right ventricle, such as using 3 and 4D echo. If we look at pulse Doppler, which should be available to most of us, and we look at the flow across the AV valves, we can see that there are two waves notable, the E and the A wave. And the E wave is smaller than the A wave. And this is different to what we see in the child and the adult, where the E wave is larger and the A wave is smaller. What is the A wave? The A wave is atrial contraction. It represents the active, energy-consuming ventricular relaxation period of ventricular filling. The E wave is the passive filling and reflects myocardial compliance. And if we do the time velocity integral of the flow, we can get an idea of the volume of blood that is passing through that valve. It's important to have your machine set up correctly, but I will not deal with that in this talk. What happens to these waves over the gestation? Well, the mitral valve always has slightly lower velocities than the tricuspid valve, and they all increase gradually through gestation. And what you also see is that the difference between the E and the A wave with maturation becomes less as the ventricle becomes less stiff, and you get more effective filling in the passive phase. We can look at the flow across the semilunar valves to get an idea of systolic function. Here we have two images on the left of the pulmonary valve, on the right of the aortic valve, in a 22-week fetus. What you notice in the pulmonary valve is you have a rather steep ascent, and the time to peak ejection on the aortic valve is longer. What we see is in progression through gestation that the peak velocity of these over these valves increases, and this reflects an increase in cardiac output as the fetus gets bigger. If we analyze the curve, our peak velocity gives us an idea of systolic function. Also, it can be helpful in assessing valve stenosis, such as a fetus with aortic stenosis. The time to peak ejection gives us an idea of afterload. I told you that the time to peak ejection over the pulmonary valve is shorter than in the aortic valve, and that's reflecting the high vascular resistance in the lungs in the fetus. If we have the flow across the valve and we know the size of the annulus, we can determine the stroke volume by timesing the time velocity integral by the cross-sectional area of the valve. And then we can determine the cardiac output by using the formula stroke volume times heart rate. And we can even work out the myocardial injection force. However, it's important to realize that this is difficult to measure these small measurements in small babies, and that because the cross-sectional area requires a squaring of your radius, you can get accentuation of error. If you look at a fetus with in this case, dysplastic aortic valve with aortic stenosis, we see that the velocity across the valve was 4 meters per second. So we can see that the fetal heart was able to create a left ventricular pressure of at least 64 millimeters of mercury. So we have a good ventricle. And that is in contrast to the failing heart in a fetus with aortic stenosis, who will have lost that high velocity. When we evaluate the pulmonary valve, the gradient across the valve is less helpful because you have a higher pressure bed distal to the valve. And so measuring gradients is unhelpful. And we have to then rely on the size of the annulus and also to look at the flow across the duct. Is there reverse flow across the duct? That will imply that you have a very severe stenosis. And there is one paper published in 2011 that said that if the flow across the pulmonary valve was more than around 90 centimeters per second, that you were likely to require prostaglandins postnatally. We can look with our Dopplers also at the myocardial performance index, and this is used quite a lot in obstetrics, especially in diabetic pregnancies and twin-twin transfusion syndrome, where we can, with the simultaneous inflow across the aortic valve and the mitral valve, get an idea of systolic function by measuring the left ventricular isovolumetric contraction time and the ejection time. And we can get an idea of diastolic function by measuring the isovolumetric relaxation time. But we want to know what the right ventricle is doing. And it is impossible in a bigger fetus to get simultaneous tricuspid and pulmonary valve Dopplers because of the anatomy of the heart. Sometimes you can do that in early gestation. So it's important then to do it in one sweep and try to have the heart rate the same when you're measuring these times for the right ventricle. It has been difficult to get concordant measurements for what is normal. If you have a look at all of these studies, they will have different normal ranges. And the reason is because of variability in how we do our measurements. So it's very important that you have a system and stick with your system. There are two proposed. The one is that you measure at the peak of the clicks, and the other that you measure at the base, at the beginning of the click. Doesn't matter which one you use as long as you are consistent. We can look at our venous Dopplers. Here we have a normal venous Doppler of a ductus venosus with the systolic and diastolic waves, a ventricular relaxation descent, and the A wave representing atrial contraction. If we look at the vena cava inferior, it is normal to have a negative A wave. And if we look at the umbilical vein, after the first trimester, it should not be pulsatile. So here we have a case of a 15-week-old fetus, was referred because of cardiomegaly, and there was a history of 2 previous intrauterine deaths. What do we see? We see a big heart with a pericardial effusion. If we do the Doppler across the mitral valve at a heart rate of 160, we can see that there is a monophasic filling. Now, if we have a look at what happens when the heart rate is 145, we can see biphasic filling. So the filling of the mitral valve and both of the AV valves is affected by heart rate. But if we have a look at this biphasic filling, we can see that the E and the A are reversed. So we have here evidence of diastolic dysfunction with an E wave greater than the A wave. If we have a look at this fetus's flow across the tricuspid valve, we can see holosystolic regurgitation, and we see monophasic filling. So this is telling us that we have a sick right ventricle. Furthermore, if we look at the flow through the aortic valve, we see a relatively normal flow across the valve, but we see that there is aortic regurgitation. And if we have a look at the pulmonary valve, we can see quite impressive pulmonary regurgitation, which is also represented here on the Doppler image on the right. If we look at the duct showed retrograde flow. So in this fetus, we had a sort of vicious circle with retrograde flow in the duct, pulmonary regurgitation, tricuspid regurgitation, and we were very concerned about this baby, and indeed it died 3 days later. So what are the more new techniques that we can use? We can use tissue Doppler imaging which tells us about the motion of the myocardium. It can give us information about both systolic and diastolic function. Here we see the S prime of the systolic phase and the E and the A prime waves of the diastolic phase. Here again, very important that you have the right alignment and that your sample size is correct and that you use a high frame rate. If you compare the systolic velocity with the TAP. So there is concordance. So once again, support for a simple way to assess a function by using your A mode. As I said, you can also see regional motion abnormalities with tissue Doppler. Here we have a patient with a big heart and a concerning area here in the left heart ventricle. And if we have a look at the, oh, why doesn't it want to go on? At the tissue Doppler, this is the tissue Doppler at the base of the left ventricle. And this is the curve that we got when we looked at the apex. Once again, confirming that there is an area of hypokinesia there. We can use colored tissue Doppler and do offline processing, and that can help us to measure cardiac time intervals. This is the child, where we can see the S, E, and A. And here we have a fetus. And once again, notice that the EA waves are reversed in the fetus. We can also measure the different motions of different parts of the heart simultaneously. Here we have in green the motion of the right atrium, and here the ventricle. Unfortunately, in the fetus, we do not have the ability to use ECG gating, but you can use the movement of the AV valves as a help to differentiate systole from diastole. So just to recap, we can evaluate diastolic function by looking at the flow across the atrioventricular valves, and we can use tissue Doppler. The E over E prime is very sensitive and a better reproducible index than the myocardial performance index. We can look for a reversal in our A wave of more than 20 centimeters per second in our vena cava inferior Doppler, and look for tricuspid regurgitation. And we can also look at our ductus venosus and look for a negative A wave. Then we come to speckle tracking, where speckles are tracked so that you can also then get an idea of the motion of different parts of the heart, such as you can see here. And you can see that the different colors represent the different parts of the myocardium, and we can see that they are contracting in a concentric manner. Here again, we can also look at deformation. We can determine strain and strain rate, and it is sold as not being angle dependent. Now, I told you that the right ventricular muscles are longitudinally arranged. So if you look at global longitudinal strain, you can get a good idea of systolic function of the right ventricle. There are now normal values that have been published, but there is no uniformity in the software that is used. And so we have different vendors, different protocols, different numbers. So we still need to uniform this, get uniformity so that we can use one language, and that would improve repeatability and our gain of knowledge. But already we see that it is helpful in identifying fetuses with twin transfusion syndrome and at risk fetuses of diabetic mothers. We have seen that it can help to identify fetuses that are at risk to develop intrauterine growth retardation by showing that there is an abnormal global longitudinal strain when the strain rate is still maintained in the early fetus. And it has been shown to be helpful in identifying fetuses in trouble with aortic stenosis. And recently there have been reports that it can differentiate the false positive from the true positive coarctation. So that will be very helpful. Cardiac MRI is becoming more and more hip and being done in more and more places. Certainly, I would say the echo is still the gold standard, but we can evaluate ventricular volume, mass, ejection fraction, and cardiac output with our MRI. But there are some limitations: cost processing, the problem of the fetal heart rate, random movements, maternal breathing movements, and especially the fact that the spatial resolution is low. So let's just look through the process of heart failure and how we can evaluate it. I said we begin with an increased end diastolic pressure and right atrial pressure. And that gets transferred into a pathological flow in the vena cava inferior, then your ductus venosus, and finally in your umbilical vein. And in the progression of deterioration, here we have the normal ductus venosus. We can see that the right atrium, the A wave becomes more and more negative till it becomes completely negative as the child deteriorates. And the umbilical vein becomes pulsatile when the child is really ill. If we look at the umbilical artery, we see loss as the child deteriorates of the early diastolic flow, and then the early diastolic flow becomes negative. So let's look at this case. This is a 26-week-old fetus referred for cardiomegaly. And what we see is a big heart. We can see pericardial effusion. We see hypertrophic, hyperkinetic ventricles. We see a tricuspid regurgitation on the color Doppler on the right. And we see also a little bit of mitral regurgitation. If we look at the Doppler across the AV valves, we can see they're still biphasic filling, but the E and the A wave are pretty similar. And there is a very impressive hollow systolic tricuspid regurgitation. If we look on the left side, we can still see biphasic filling of the left ventricle. So that looks pretty normal, but there is a little bit of mitral regurgitation. As an addition to the pericardial effusion, this patient had ascites and significant skin edema. The ductus venosus was extremely abnormal with a very negative A wave. There was loss of end diastolic flow on the umbilical artery Doppler. And if we looked at the vein, we could see that it was pulsatile. So if we look at a cardiovascular profile score, which is a score that helps us to evaluate fetuses with 5 main important parameters: the arterial umbilical artery Doppler, the cardiac function, the heart size, the venous Doppler, and the presence or absence of hydrops. A normal baby gets 10 points. What does our baby get? Our baby loses 2 points for skin edema, loses another 2 for having a pulsatile venous Doppler. Cardiomegaly helps him to lose another 2 points. He loses 1 point for his holosystolic tricuspid regurgitation and for the loss of his end diastolic flow on his umbilical artery Doppler. So he gets a score of 2 out of 10. This is very poor. And mortality has been shown to be significant in a score less than 7. So the prognosis for this baby is poor. And indeed, the baby died a week later. So what are the take-home messages? Fetal cardiac assessment is multimodal and ongoing advances are occurring in many spheres. Tissue Doppler imaging, speckle tracking are new techniques that are helping us to assess the regional and global myocardial function. And they may be helpful in detecting cardiac dysfunction in at an earlier stage. Operator experience is important, despite all technical advantages. Deciding when and how to deliver a fetus with cardiac dysfunction remains challenging. And we have to also consider the fetus with a cardiac dysfunction. Will the left side be able to take over once the baby is born? Ideally, we need reliable online, real-time right ventricular assessment and the ability to predict cardiac function before the signs of fetal distress set in. Currently, I think that the mainstay of assessment remains still the 2D, the M mode, and the conventional cardiac Dopplers with the myocardial performance index and what we call the obstetric Dopplers, the umbilical artery, the middle cerebral artery, and the umbilical vein Doppler. I thank you very much for your attention.
Thank you so much, Sally, for such a beautiful and really simple and focused presentation. We'll just have a few minutes for questions from the panel. Oh, I see a lot of panelists joining us. I'd like to welcome Wayne Trotsky and I think Anita. I have a question for you. Thank you so much. I wanted I like what you said that the global strain rate. So we go by global, right? rather than for the right ventricle and the left ventricle. Now, you said the global will tell us the difference between the false positive coarctation and the real coarctation. How will it do that?
Well, I think that our next speaker might tell us something about that, and I don't want to tread on his toes.
Well, he's going to go talk about anatomy.
I don't know, but maybe he's going to answer it. Maybe he would like to answer it now.
Mark, do you know anything about the global strain rate differentiating between the true coarctation and the false coarctation in utero?
2 words, stay tuned. That was a fantastic talk, Stelliane. I just want to congratulate you and thank you. But no, I'll talk a little bit about that in my talk.
Okay. Other thing is that I like what you said about tissue Doppler being there's a positive correlation between tissue Doppler and TAPSE. Is this well known and accepted, or a personal?
No, it is not my research. It's research that was done in Barcelona. I think it's Crispy's group that showed that there was a correlation between the two, and we all have M-mode, so we should all be able to do TAPSes and MAPSes.
So you advise to do TAPSE and MAPSE because we don't know what's the absolute number for gestation, do we?
Well, there are normal ranges available.
Okay. So, is there a number that you tell us that we say, oh, it's below that, that's bad, or for the right side and for the left side?
I think you have to look at the normal ranges. Okay. I'm just encouraged if I get a nice number greater than 3.
Okay.
But so that's just my personal experience. That's not based on any graph or personal study.
And you like tissue Doppler? You do tissue Doppler in the clinic?
I do tissue Doppler in the clinic when I have a fetus that has got a myocardial functional problem. We have recently been determining our own normal values because that the normal values are also operator dependent. There's no problem with so you need to know your own normal values for your own machine, and that is one of the limitations. And so I'm also getting to the point where I'm going to be using it more and more because now I can better differentiate between what is normal and what is not. So that's a working process for myself.
Norm, do you have any comments? Dr. Silverman, hello.
I just want to ask a question to Sally about strain regarding the differences in fetal strain from machine to machine after birth. Of course, this has become terribly important that not all machines give you the same rate. So not only have you got your own laboratory to consider, but only what kinds of machines you're using in your laboratory. And the laboratory that I worked in, they're often different machines, so it becomes a real problem. What can you say about that?
I can only reinforce what you say, and I think that we need to endeavor as a professional body of cardiologists or fetal cardiologists to try and make some kind of a consensus about what we're going to use and how we're going to do it.
Right.
Because I think the bottom line that the vendors would say, we don't have anything standardized, but if you take the trend where a patient comes to you and you do the strain, follow-up strain and follow-up strain, correct? I mean, well,
that is one way to look at it. But if you have one opportunity to make an evaluation, then you need to be able to differentiate between is that what I see now good or not?
Yes, the same machine, using the same machine, right? But they're doing something called standardized method where you can do one patient on different machines now. I've just heard one of the vendors talk about where they're going to standardize all these things and you can do the patient on different machines with same value. I'm not sure.
Well, that would be fantastic.
Yeah, thank you.
Yes.
Thank you. One question from the audience. Do you have a favorite objective parameter to assess RV systolic function? A favorite. She's asking about a favorite.
A favorite. Well, I look at the degree of tricuspid regurgitation, and I do my TAPSes. Yeah, I think autopsy is helpful. And I always measure my flow across my AV valves.
You do TAPSI, not MAPSI?
I do both of them, but the MAPSI is usually quite difficult. Small measurements. And primarily you're interested in your right ventricle in the fetus. I mean, the left ventricle is important for what's going to happen postnatally.
Yeah, because as the dominant ventricle is the RVs, you're really interested. You said that I don't know when to deliver a fetus with heart failure and the mode of delivery. Do you go by the score? Because I think Dr. Huta also mentioned before in his reviews that I think below 7 is cesarean section.
Sorry, he said, what is cesarean
I remember Dr. Huta, regarding the score, it helps to get to know the mode of delivery and timing of delivery. If it's below 7 or 6 and something like that, so this is probably cesarean section.
Yeah, well, you can also ask yourself, for example, in my patient, whether you would be active at all. I think that's something that you also have to think about, because you need to look at the gestational age, what the score is, and see what is reasonable therapy. And certainly a child that is in the latter gestation and is in cardiac failure, I would go for a cesarean section. Yeah, because the child is already in heart failure.
Thank you so much. I think it's time to move to our next.
One question
sure.
About the Huta index, the myocardial performance index. I'm at 2. Of course, Sally is really pretty bad. I think in my experience in some studies that 7.5 is like the cutoff between good prognosis and bad prognosis. Can you give us any idea along that line, please?
I think that you're absolutely right. The odds ratio for bad prognosis was a score under 7. And you want to intervene when you still have a chance that you can save the fetus. So I think that is a pretty good suggestion.
Sally, would you treat in utero for heart failure?
Yes, I would, but I mean, we haven't got very much available to us. We only really have digoxin.
Okay, thank you so much. I'd like to move to the next speaker and old friend and colleague, Dr. Mark Sklinski, the Chief of Pediatric Cardiology at Metal Children's Hospital, UCLA, founder and medical director of the UCLA Children's Heart Center, director of the UCLA Fetal Cardiology Program, co-director of the UCLA Congenital Pediatric Heart Program, lots of publications and lots of presentations, and he's a great teacher. So he goes from basics to the advanced, and we chose a topic to Dr. Sklinski. Tell us about coarctation, pitfalls, and the diagnosis. And to our audience, one of the most difficult, really, things to diagnose, to miss in the diagnosis, subtle coarctation or development of coarctation few weeks postnatally due to a nidus in the prenatal time. Thank you so much, Mark.
Thank you, Rima, for that kind introduction. Can you tell me if you can see my video running okay?
Yes.
Thank you. So again, thank you, Rima, and thank you to the Congenital Heart Academy for inviting me to join for today's session. And it's a great pleasure. And Sally, thank you for that fantastic talk. I'm glad that it's going to be recorded on YouTube. There's a lot of information there for all of us to go back and review. We're switching gears a little bit. This is much more looking at qualitative assessment of the heart, although there's aspects of quantitative evaluation of the heart that are really important too for coarctation of the aorta. So I think everyone on this call realizes that coarctation of the aorta is phenomenally important to pick up early. I'm not going to be addressing all the data to show that. I think I'll be preaching to the choir. But I will talk about other aspects of how difficult coarctation is to detect early, not just prenatally, but postnatally, and why it's so important. And then I'll give you my own ideas about how we can be better at picking up coarctation of the aorta, both as a screener and at the time of fetal echocardiography, which are very different exams, or can be very different exams, of course. So this is a nice paper if you haven't seen it. It's one of the more recent ones, looking globally at detection rates for congenital heart disease. I encourage you to look at it if you haven't seen it. This came out in 2019, looking at the detection rates for severe forms of congenital heart disease. And for the purpose of this talk, just look at the column underneath coarctation of the aorta. Clearly, there's a variation in detection rates. Most places in the world, it's a very low detection rate, particularly for isolated coarctation of the aorta. As we all know, it's very difficult, but there often are clues, and that's what this talk is about. But I alluded to earlier that I wanted to talk briefly about why it's so important to pick up prenatally in terms of the difficulty with postnatal evaluation. This is physical exam. Many of us are pediatricians as well. This came out in 1999. There are many papers when I reviewed the literature that came out around this time showing that routine neonatal examinations fail to detect, in this case, more than half of babies with heart disease. And that's really continues to be the case. This is, sorry about that. This is a paper that came out in 2014 looking at late detection of critical forms of congenital heart disease. It was data reviewed. This paper reviewed data from the National Birth Defects Prevention Study, live-born infants born between 1998 and 2007 with severe forms of critical congenital heart disease. And late detection was defined as over 3 days after birth. So they looked at 3,746 babies with non-syndromic critical forms of congenital heart disease, and late detection, meaning beyond 3 days after birth, was in 30% of these infants. And if you just, for the purposes of our time, look on the bottom, 60%, more than 60% of infants with coarctation were detected late, meaning after 3 days. Following delivery. And this is another paper. There are many out there from 1990 showing why, giving some insights why there's such a delayed detection of coarctation. This was in practically 80% of cases of coarctation. Pulse discrepancy was found to occur in this particular series 3 to 5 days postnatally, and upper extremity hypertension, which of course is difficult to measure hypertension, but if you try to measure it, in this particular case series occurred after 5 days. And of course, in much of the world, newborns are discharged well before that, often within the first couple of days after delivery and uncomplicated deliveries. And pulse oximetry, unfortunately, left heart obstructive lesions, which of course includes coarctation, are not particularly good at being detected by pulse oximetry. This is a paper came out in 2015. There are many such papers showing that coarctation is difficult to detect using pulse oximetry. They found 90 cases of isolated coart, only 3 of whom were diagnosed prenatally, which is the point of this talk in large part. 19 of the remaining 87 cases were born in units with pulse oximetry screening, and among those 19, only 4 screened positive. The rest failed to be detected with pulse oximetry. And of the remaining 83 cases, 43 were discharged undiagnosed, and likely we're going to have a late, quote unquote, late detection beyond 3 days. So that's just by way of introduction. Now let's talk about the meat of my presentation is tips and tricks for detecting coarctation, given the challenges with early postnatal detection. We all know it's very hard to detect prenatally. This is just a bunch of different lesions on the sides. In the middle, it's coarctation, which, as we know, is one of the most difficult forms of severe heart disease to detect. This and total anomalous pulmonary venous return. This slide is the answer for, in my opinion, large part of why coarctation is tough to detect. And the answer is that it's sometimes tough to get good pictures. So this talk is largely about getting good pictures. I think now evaluation, certainly quantitative evaluation, starts with good pictures. If you don't have good pictures, don't have the right angles of acquisition, you're going to miss heart disease. And I think honestly, that's a huge part of why heart disease is being missed, including coarctation of the aorta. So I just briefly, many of you are aware of this, but for those who are listening or watching who have been doing this less, I think it's important enough to review. We need to optimize the probe resolution and choose the best probe, usually the one the highest megahertz. Start with that and see if you get adequate penetration. Optimize the probe position on the maternal abdomen, very important. Don't just stay in one's place. Keep moving around. And if it's a good place for 1 second, it may be not the optimal place the next second, or if it's the optimal place for one view or one structure, it may not be the optimal window for another. Optimize the maternal position. That means having her move back and forth on her sides, depending upon what you're trying to see and how the baby is positioned. And optimize the fetal positions. How do you make the baby move? Well, we all have our tricks, but it's important to keep that in mind. If you had the mom go to the bathroom, walk around the room, do some jumping or something like that, you may be able to get the baby to move, and it could make all the difference between detecting or missing congenital heart disease, including cohort. Then optimize transducer pressure. You need to sometimes give a little bit more pressure than you may be accustomed to. And of course, optimize the depth and the sector width and the zoom. All these are really very important in terms of detecting coarctation in all forms of congenital heart disease. Now, another aspect that is really important is the angle. This is a picture of a mirage, right? It looks like water on the road. We've all seen these, but it's really not. It's a optical illusion. And how do you know if it's real or not? Well, you either get closer, then it goes away, or you move your head around and you look at it from a different angle. Same concept applies when you're looking at the fetal heart. If you want to see if something's real or not, you want to see the heart structures accurately. You want to minimize artifact related to angle. And so you want to angle when you're looking at the aortic arch or all structures of the heart, you want to optimize the angle. This is looking at left ventricular outflow tracts. This is not the way to look for the left ventricular outflow tract, for instance. If you want to look at that, this is my favorite view. You want to be relatively perpendicular to the septum, see the left ventricular outflow tract, and then when you sweep, you can see the crossing. It's a very powerful view, and the angle is so key. And this is maybe my favorite view 2.0. You stay in the same portion of the maternal abdomen, but with a little bit of manipulation of the angle and direction of the probe, you get the inflow, and you can see the crux of the heart and the inflow septum, which sometimes can be difficult to see. And then what I'm talking about today in terms of coarctation is both in terms of thinking in terms of those who do screening and those who are doing detailed fetal echocardiography. In terms of screening, we always think about situs, different kinds of views. But remember, when we're optimizing image quality and optimizing angle, it's not just a checklist. Did you see all these things, which are, unfortunately, from a medical legal standpoint, frequently people just look, did you see the 4-chamber view or not? But it's really the quality of the image and the angle that you've seen things. And this is all relevant for coarctation as well. And then in terms of fetal echo, it's not just have we seen all the structures, but have we seen the structures well? And have we seen them with the correct angles? And I think really that makes a huge difference, makes the difference in many cases. And in my practice, I always use a foot pedal, because to get the right kind of image and the right angle and the right transducer pressure, and to hold that there for long enough and to acquire the image, and to protect my shoulders, I need two hands on the probe. And so if you haven't tried that, I encourage you to try two-handed scanning. And for that, you just need to get a foot pedal, not that expensive, and it's relatively easy to do and a very important part of our practice. So this is a nice image from Jack Reichick's book showing coarctation in a schematic model. And this is just an example of coarctation on the right. Now let's talk about some tips and tricks that I use. And it all starts out, all these images are images that I've obtained just by using the techniques I just described, nothing more. And so on the left, you could see a normal aortic arch. Normal the aortic arch, the isthmus does get smaller than the transverse arch. There's normal narrowing there. You can see the head and neck vessels. You could see the ascending aorta. On the right, what's the difference? Well, the difference is, first of all, it's a sagittal image. So this is not something we're doing on screening. That's important. So we're not going to see the whole aortic arch like this with a screen. So, but if we're doing a fetal echocardiogram, then we should get the aortic arch. And when we get it, we want to do it. We want to optimize the image so that we see it really well. And we could have a judgment in our own mind qualitatively if things look normal. But then we could also measure in a quantitative fashion the diameters of the ascenior, the transverse, and the isthmus in a way that's reproducible and reliable. And here you can, without z-scores, you could see it's a hypoplastic transverse arch. You could see the posterior ledge or shelf right here. And you could see the ductus is going to insert right here. So it starts out with image and getting the sagittal view, which is, of course, not part of screening. CoAo flow, I just mentioned briefly, there are some data showing, I mean, CoAo flow, the flow in aortic arch should be prograde. This case, you can see is bidirectional flow. We're still learning a lot about normal flow patterns in the distal aortic arch. Sometimes we see it, there's some reversal for part of the cardiac cycle, and these babies often turn out to be normal. I think there's a lot more to the story in terms of what contributes to the Doppler waveform in the transverse aortic arch. It's not always coarctation of the aorta. There's other factors that we're learning about. But CoAo flow, I think, should be part of the evaluation for coarctation. This is a sweep. Sweeps are very important, of course, for evaluating for congenital heart disease, both in terms of screening and in terms of at the time of a fetal echo. This sweep shows you the differential in ratio between the very large ductus and the very small transverse arch. And of course, the ratios are very important to look at too. Just qualitatively, if there's a huge discrepancy in the transverse arch or the aortic arch and the ductal arch, as there is in this example, that's very concerning. And there are norms for what the aortic arch should be, what the ductal arch should be at different points. And of course, there's norms for the ratios as well. But again, it all starts with good image quality, getting the right angles and in a reproducible way. If you don't do that and you start to measure ratios quantitatively or measure specific structures quantitatively, you're doing a disservice because actually what you find may be misleading. This is the 4-chamber view, getting to what Sally was talking about when she started talking about speckle tracking, but I'll get to that in a second. The 4-chamber view is commonly abnormal with cohort. It's not always, but it's commonly abnormal. And it's the take home here is that left side is with coarctation, the clue to coarctation is that left side of the heart is generally small. The problem is in a normal fetus, the right heart is bigger than the left heart. It's just a matter of degree. So again, the importance of image quality, getting multiple views, optimizing the angles. Here you can see in both cases, the mitral valve is much smaller than the tricuspid valve. The left ventricle is a little small, but contributes to the apex. So we're not talking about hypoplastic left heart. We're talking about ventricles with hearts with the left side that does contribute to the apex and is squeezing well, but it just looks a little smaller than it normally does. So that's the first thing to check. But then after you see that, then quantitative measurements can be very useful in terms of the measurement of the mitral valve annulus, the measure of the aortic valve annulus, and other measurements. But these measurements rely on really good image quality so that you can make these measurements reproducibly. So when I measure these, I always measure multiple times on myself just to make sure, and I go back and forth, take the probe off, go back, make sure that it's reproducible. And these, of course, are views that are seen with screening. And here's some other clues. On the left, you can see a dilated coronary sinus. An LSVC to coronary sinus has been shown sometimes to be a marker for coarctation. So when we see an LSVC to coronary sinus, even if everything looks normal and I do not suspect coarct otherwise, I'll always get an echocardiogram on those babies after birth before they leave the hospital, if possible. Some communities that's not possible, but if it is possible, I recommend it. Also on the left, what do we see? On the left, we see that there is a pericardial effusion. Every fetus has fluid around the heart. It's a matter of degree. So you have to be, after you're scanning a lot, you start to know what's not normal or not. This is not a normal amount of fluid. There's more fluid than normal, and that can be a very non-specific marker for cohort, but it's something to consider in your mind. And on the right, we're not seeing the effusion, but we're seeing the dilated coronary sinus and a little bit of right heart disproportion. So this is getting at the speckle tracking. It's a long discussion on of itself, but I do find speckle tracking technique to be very useful in terms of training our own eyes in terms of how to look at heart function. This is a normal normal heart on the left, and using speckle tracking, this is software developed by Greg DeVore. You could see on the right how this particular heart squeezes, how each speckle, and 24 segments, how each speckle on the endocardium moves during the cardiac cycle. It's very interesting. I never, until recent years, started looking in such detail at how each part of the heart moves. How does the septum move towards the apex in the RV compared to the LV? It's very interesting. You could spend a lot of time just looking at this one slide, as I have. So how does that apply to coarctation of the aorta? Well, turns out that it's possible, and I said stay tuned before because we're nowhere near the point of being able to use speckle tracking to diagnose coarctation. But we're at the beginning, and there may be some clues there that we have not yet discovered. This is speckle tracking, Greg DeVore's software applied to a case of coarctation. You could see on the left, it's a dilated right side, it's relatively small left side, contributes to the apex. But you could see each speckle, how the speckle moves during the cardiac cycle. And if you take some time, you'll notice that there's marked differences between this heart and a normal heart. And likewise on the right, this also using speckle tracking, you can see septum motion and the free wall motion of both ventricles is distinctly different. And with speckle tracking, as Sally was talking about, there's a lot of potential for quantitative evaluation. That can be very useful, perhaps to help us identify fetuses at risk for coarctation by looking at the 4-chamber view. We're just not there yet. But again, very important, cannot use this in a reproducible way without getting really pristine 4-chamber views, very good image quality, the right angles, and you need to, part of that is blowing the heart up so that it occupies a big part of the screen, which we should be doing routinely anyway, but it's particularly important when we're going to do quantitative measurements such as speckle tracking. So now let's get back to screening. These are some screening views, at least the one on the right, maybe not the short axis one on the left, but certainly on the right. A screener should be able to see what the aortic valve looks like, a bicuspid or small aortic valve annulus, or a thickened aortic valve. Those can all be clues for coarctation of the aorta. Also on the right, you can see a dilated coronary sinus, which also is part of a screening view. On the left, we could see the disproportion of very large PA. And again, PA should be bigger than the aorta during the fetal life, but it's a matter of degree, and that's where Z-scores come in, and that's where the importance, that emphasizes the importance again of image quality. This particular view, this may be a bicuspid aortic valve. Can't tell for sure right here, but I think it was a bicuspid aortic valve. But also it's just a size discrepancy. And then here we get to the 3-vessel view, which increasingly is being used even at the time of screening. I think it should be part of the screening evaluation with and without color. We're clearly not there around the world in terms of doing this for every low-risk fetal cardiac evaluation. But I think we're going to get there at one point. So on the left with CoAo, you could see, what are we seeing? Well, first of all, we're seeing from a CoAo standpoint, the flow is going the wrong way in the aorta. You can see the discrepancy, prograde flow in the PA, retrograde in the aorta. You can see the marked size differential. So from your eyes standpoint, and you can measure, you could do some quantitative measurements from this view. And then lastly, we could see it's a 4-vessel view. We're actually seeing a couple of different SVCs. Here on the right, here in the middle, it's the same thing. It's just an older study, but you can see the right-sided SVC, the left-sided SVC, and then the large PA and the smaller aorta. All of these are clues to that they do not definitively say that this fetus has cohort, but it's a risk factor for cohort. And then on the right, again, the size discrepancy, very large PA. You have to come up a little this higher in this case to see the smaller aorta. So these are all clues that we use. This is one other clue, is the ascending aorta, that we found to be helpful as well. It's not borne out in all studies, but we found this is a study by Sunita Nuwitnaween, an MFM from Bangkok, who spent time with us. The ascending aorta is a very valuable structure to look at and to measure, and may be helpful in the context of detecting coarctation. So these are just to review some screening clues at the time of a low-risk screen, a bicuspid aortic valve or aortic stenosis, a valve that doesn't look quite right in terms of the leaflets, or if the annulus is small, a left-sided SVC with a dilated coronary sinus, a small ascending aorta, a small mitral valve, and right heart disproportion. Non-specific, but can be a subtle clue. This is a couple examples. On the left, it's a form of severe aortic stenosis. You can't even practically see the aortic valve, but it's there. It's just small and thickened. Here on the right, it's well developed, but a little thickened and likely bicuspid. Whenever you see aortic stenosis in a fetus, that's a risk factor for cohort. So even if the aortic stenosis is mild and will not require early intervention, it's the coarctation that we should fear. It's a coarctation that we don't want to miss. So that's another message is we need to be very careful at reviewing a fetal heart as well as we can at the time of screening and at the time of a high-risk fetal echo. It's going to be difficult. In some cases, we can be definitive that there's cohort, but in the vast majority of cases, it's going to be that we're suspecting cohort. We're not going to be able to be definitive. We're just going to be able to identify a fetus at risk. We could stratify how high the risk we think it is, but the bottom line, any fetus that we feel is at risk for cohort should have evaluation after birth. That's another topic of discussion I'll mention in a couple of minutes. Here's just a nice schematic from Cardiac Health showing a normal tricuspid aortic valve and then a bicuspid valve with fusion of two of the leaflets. And here on the right, you could see a sort of a fisheye opening. This is not an easy view to get, as all of you know, but with practice, we can get better and better at evaluating the aortic valve from a parasternal short axis view like this, which can be very helpful. Here's on the left, the Mercedes sign in a normal aortic valve that's tri-leaflet, tricuspid, and here on the right, the bicuspid valve. LSVC coronary sinus, I alluded to earlier. You could see on the left, dilated coronary sinus. On the right, you could see the coronary sinus is dilated in cross-section at the level of the four-chamber view. Here, the same thing. You could see dilated coronary sinus with a narrow left ventricular alpha tract in both cases. And this is just a schematic showing the way the LSVC can dilate the coronary sinus and the way this can appear depending upon your level. And finally, this is a nice study that came out. Now it's 5 years or 6 years, I guess. Again, just emphasizing the importance of diameters of left-sided structures, the mitral valve, the aortic valve, the isthmus, and the aortic arch itself, and then the ratios that go along with it. And of course, some of these structures we evaluate at the time of screening, like the mitral valve and aortic valve. Some we only see at the time of the fetal echo. But in any case, it's important to get really pristine views with the right angles and to measure them reproducibly with z-scores that can be reproduced. That's the bottom line. So I had mentioned coarctation is so important to detect prenatally because it's difficult to detect after birth. And I left for another time the importance of early detection because I think all of you know that. So given that when we suspect coarctation, we need to be very conservative and to have follow-up after birth, even if we have a mild suspicion or a high suspicion. So what is the right neonatal management? How should we take care of these babies that prenatally we would suspect them to have cohort? We're not sure. We may have a high suspicion or a low suspicion or a medium, but how do we take care of them? That's a whole other discussion as well. This is a paper that our former fellow, Sonia Hedy, published on neonatal management of prenatal suspected cohort, because we want to do the right thing and not miss cases before they go home. But at the same time, we don't want to take all these babies and instrument them, put lines in, intubate, start prostaglandin, and so on, take them away from their mothers prematurely. So there's a lot to learn in terms of being careful and how we take care of these babies after birth. So finally, for my take-home points, coarctation of the aorta remains very challenging for all of us. All those of us, myself included, have been practicing for several decades. Very difficult to detect prenatally and postnatally, but it begins by optimizing the image and the angle of acquisition, something that we all can get better at. And I think it makes a huge difference in terms of detection rates for all forms of congenital heart disease. We can identify clues at the time of screening on the 4-chamber LVOT and RVOT and 3-vessel and sagittal views, either at time of screening or at the time of the fetal echo, all really very important and can be very, very helpful. Of course, the most important clues with the highest likelihood to be correct are if you open up the aortic arch. You can see the area of coarctation, but even that's challenging, as you know, because it's going to appear much different prenatally than after birth when the ductus closes. And then translation of prenatal detection of congenital heart disease into optimal outcomes. This is not just true for coarct, but for all forms of heart disease. Major heart disease requires a collaboration, of course, between maternal fetal medicine and pediatric cardiology. And then finally, cautious postnatal follow-up for cases of suspected coarctation of the aorta. Now, I'm so delighted that doors are open, that we can see each other more commonly now around the world, that we're very happy to have people coming to visit us here at UCLA. We welcome anyone who wants to reach out to me. We could arrange a visit. So again, thank you to the Congenital Heart Academy and to Rima Badr for inviting me.
Thank you so much, Mark. Beautiful talk, and I'll open the floor for discussion. And I wonder if Wayne is with us, if he can just also share, and Dr. Silverman as well. You said something beautiful. To start with, you have to get to optimize your image, right? So what are the advices to people? You said use the high frequency probe, right? And probably use a sector and get the mother to move. What else? I mean, your images were beautiful. Do you use filters? Do you use, what do you, and you're using the golden, a lot of people like to use the black and white one.
Yeah, thank you, Rima. Yeah, I put all those in the slide for, it's going to be on YouTube. People can review that again, but I like CP. I don't think that's that important, to be honest. I think what is important is to, whatever machine you have, you may not have the best machine in the world, but you could still do a lot to make the image better, some of which we've talked about, making the heart really big to occupy a big part of the screen, and to put the focal zone where it should be, to use transducer pressure to get the baby in the right position, and really important, keep moving around on the maternal abdomen, big movements to get the right place, and the right place at one point in time is not going to be the right place even a few seconds later, and it may not be the right place for a different structure than what you're looking at currently. So I think all those are really very important and do make a huge difference.
Adam and Sally, do you have any tricks and tips in the image acquisition in coarctation of aorta? Of course, we have to say this is dependent on the body build of the mother. She's not 100 kilos, usually 75, 80 or something like that. So what are the tips and tricks that you do to minimize, as we saw from Mark said, this is one of the, I think, one of the most missed diagnoses prenatally, especially the subtle ones.
Yeah, I think a lot of this have been told previously. So of course, we use transducers with lower megahertz, and sector probes are very good. The only thing that you have to be aware of are the indices that are very, very high sometimes when you use the sector probes used normally for adult hearts, really. So this is something you have to take care of. My question is a little bit different, because quite commonly, the reason for referral is the ventricular imbalance. And certainly there is a difference between the fetuses that were okay at 25 weeks, for example, and then in 32nd week, they start to get the imbalance, and you look at it, and you can see that there is some restriction of foramen ovale maybe. And the first thing that I'm usually checking at these times is the flow in peripheral pulmonary arteries. There is a high resistance. It means that there is no blood flow to the lungs. So there is no blood to return to the left atrium. So the left ventricle is underfed, but it is a late event. So it's less likely that this ductal tissue will take over the isthmus area and they will develop coarctation. And these are the fetuses that routinely get hyperoxygenation tests to see if lower pulmonary vascular resistance fills the ventricle, and if it restores the normal, let's say, or close to normal size and normal isthmus flow. So what do you think of this kind of approach?
Adam, let me just make sure that we got you right. You're talking about coarctation or hypoplas in progress.
I'm talking about the risk of coarctation, because when in general we know that the fourth aortic arch tissue is flow dependent, so it's stimulated by flow. When there is no flow, the sixth aortic arch tissue, that is the ductus arteriosus tissue, takes over the isthmus area, and this is why they develop coarctation. So when the arch area is more or less normal throughout the pregnancy, and then in third trimester it starts to get smaller, and there is this a little bit of reverse flow, or there is almost no flow to the isthmus, because the left atrium and left ventricle are underfilled because of high pulmonary resistance, especially in the setting of mild foramen ovale restriction. Then when you give them oxygen, usually the higher pulmonary blood flow fills the left side, and you can see that most likely it's gonna be good. So what do you think about this kind of approach?
Yeah, thank you, Adam. Thank you. Thank you for bringing that up. I agree completely. For just a few comments. First, I do think we're all learning a lot about fetal physiology and the role of maternal hyperoxygenation as a test, not necessarily as a therapy, but as a test, as you described. And I think there's probably coarctations of the aorta where that can be helpful to allow us to figure out if a fetus has coarctation or not. But I think the vast majority of coarctations, we do not need that technology. We just need to image the heart better. We need to get sagittal images of the heart, of the aortic arch. We need to get better views of the fourth chamber. We need to be able to get more reproducible Z-scores. So I think most cases of cohort, we don't need that to differentiate. And the fact is, most places don't have the time or sophistication or equipment to be able to do maternal hyperoxygenation. But those who can use it and can advance the field and teach us about fetal physiology. And in some cases, I think it will be useful to help identify cohort. But like I said, I think most cases are going to be more straightforward, I would think, if we get good images. So I think it's an important role for those of us who can do that. I think we need to continue to study that approach. And I guess you'll teach us more maybe next time.
Wayne, do you want to say anything? Wayne?
Yes,
Wayne?
Hi, everybody. Can you hear me okay? Yes. Well, first of all, thank you to both Sally and Mark for excellent presentations, and hi, Adam. So, I think we take a very practical approach to coarctation, and we use the term suspected coarctation in many of our patients because, at the extremes, obviously where there's absolutely severe hypoplasia, that's pretty easy. And then when it's, we get a lot of late gestation referrals, suspected coarct, where there's really RV-LV disproportion that is basically normal. But once you mention the word arch hypoplasia coarct, everyone gets all excited. And so, we take a practical approach to those, the ones that we overcall. We basically say, leave them in the nursery, we'll echo them there, we'll watch for coarct, and make sure the duct is closed before they go home, and even deliver them at local hospitals as long as they can get an echo before they go home. Those are the ones that are sort of suspected but low suspicion. And there is no question that many times I've counseled families that I've said, I really think this one's going to be a coarct, and it ends up not being a coarct once the duct closes and the left heart feels better. We've all been in that situation. And I think that a lot of this is our own obsession to try and be perfect with everything. We always like to make the diagnosis. And I think this is one of those diagnoses where you absolutely have to overcall some and undercall some. And that's just the way it is. And the only thing that we should do is just check on the baby after birth and make sure. The ones that get missed, it's probably a normal fetal ultrasound at 20-something weeks, a low-risk pregnancy. They never get seen again. And those absolutely could. We still see babies come in with coarct. So I think, it's a difficult thing to get right 100% of the time, especially in the mid-range. And so we just take a very practical approach, which is, we say, let's see after birth. And even the diagnosis,
Wayne, I'd just like to learn from you. Now, this is a very generous comment, because we have a mother who's very worried, and we don't want to tell her that there's a coarctation, and yet there could be a coarctation, and she's pregnant, and breaking the news as physicians is fine. Now, what are the red herrings that when you're scanning, do you look at the isthmus size? Do you compare the isthmus to the left carotid? Do you do anything else? You look at the 3 vessel. What are the things like what we learned from Mark is the bicuspid aortic valve, the dilated coronary sinus. Now, the RV to LV discrepancy, I think this is before 32 weeks, right? Not after, or you take it at any
that's right. I mean, that's right. I mean, you obviously ones that have real coarct often will have discrepancy early on. We don't specifically use any metrics. Often, I think eyeball looking at it is probably the most important, and sort of obviously if the isthmus, mostly if the transverse arch is very narrow. But I think that a lot of these metrics people have come up with. There's a million studies on fetal coarctation out there, and none of them absolutely predict things with 100% certainty. Even the diagnosis of coarct is relative, right? We have some patients that have a mild or even moderate coarct normal function. We send them home and repair them at a few weeks of age, as long as they're stable. So, the diagnosis isn't really all or nothing either. And so, so I think, again, it's one of those things
you keep them in the hospital till the duct closes? Would you keep them in the hospital till the duct closes?
Yeah, certainly till the duct closes. But, even some that have preserved function, and we'll see them, if we send them home, we'll see them often, maybe even weekly, and obviously tell the parents about symptoms. But there are some that we've sent home and repair them later on, obviously in the milder range. And even those that were suspected prenatally. So I think that in the end, this is really one of those things that is much more our obsession as doctors, trying to get everything perfect, than just being practical about it. And I think that I don't know how many times I've been certain it was a coarct, and after watching it, it wasn't. Or at least, they have mild hyperplasia, but they didn't need surgery. And even I think the one that really fools you is the one where there's premature closure of the foramen, and the atrial septum is bulging right to left. In that case, you have, as we heard, that only say 20% in late gestation of cardiac output goes through the left heart. You can get left heart, a skinny left ventricle, and you can even get retrograde flow in the arch because it's just a volume issue. I've seen patients like that. Once they're born and they fill their left heart, there's no coarct, there's antegrade flow. So you have to be careful of those that just because there's retrograde flow in the arch and what you suspect a coarct doesn't mean there will be a coarct once the left heart fills. So I think there are many nuances here, including LSVC to coronary sinus. So in the end, this is not a game of trying to predict with 100% certainty. I'd say just check the baby after birth. That's mostly, don't let them fall through the cracks.
Thank you.
I think there's one more issue. So sorry, I started to talk. There's one more issue because it somehow relates to what Wayne said. When the ventricle is underfilled, there must be a reason for that. And occasionally we look for coarctation, but we miss the reason to have underfilled left side of the heart. Like, for example, parachute mitral valve as mild mitral stenosis that leads to this underfilling, and it shows like a prenatal coarct, but in fact there is another kind of issue. So when we suspect coarct, maybe we should take a closer look at the heart as a whole and not say, oh, it's coarct. So this is just another comment I want to add.
My question was about the postnatal care of these babies, because it's great. Of course, we're going to follow them up and we're going to see what happens, but we have to also make a plan. Where is that delivery going to happen? What kind of level of care is available? Does the baby have to go to the neonatal intensive care? And it's also you have to think about what the facilities are in your hospital. Now we have a situation where we have a delivery room where the mother has delivered and she can be with the baby. But if the baby is admitted to intensive care, there are only a few beds where the mother can room in. And so then you are committing the baby to separation from the mother after birth if you say that this baby has a high risk of coarctation and needs to be monitored adequately. Ideally, I would like to put a little saturation monitor on the foot of every single suspected coarct for 48 hours or so and see if we see a reduction in our pulsations at some stage as a kind of a easy baseline next to the bed way of monitoring these babies. But the reality is that this seems to be too difficult for in the delivery ward. So how do you differentiate between the babies that can stay with their mothers and those that can't? How many markers do you have to have seen? How do you, where do you make your cutoff? And I was also interested that you didn't mention in your talk the direction of flow across the foramen ovale. I wondered how important the prograde flow that we see sometimes in the distal arch is. And I wondered also about the branching pattern of the arch, whether you take these also into consideration in your evaluation.
Thank you, Sally. Those are all great points. I'm going to try to remember each one. So first, I think the discussion of how to manage these babies, and this paper that Sonia published from our experience was our suggestion of how it works here. But I think how we manage these suspected cases after birth is very important, as you point out, and may have important implications even where you deliver a baby. Or do you have give the mother 5 minutes of skin time or not? Or do they go to the NICU, or can they room with their mother? I think we need to use instance, and each institution have its own approach. But it's important. We do stratify high risk versus low risk, and we manage them a little bit differently. We don't have the time to go on to, I think it's a very important area though, because as I mentioned, as Wayne emphasized, it's important to identify fetuses at risk. And then how we manage them after birth is really very important. In terms of the, I'm sorry, that's all in terms of time, that's all I'll say now. Then in terms of the CoAo flow, and what Adam pointed out, obviously with very good imaging, the very good imaging is so that we can identify, is there mitral stenosis, is there aortic stenosis, is there something else going on? And of course, we want to look at the foraminal valley flow. I think there may be differences in flow pattern across the atrial septum. I find that sometimes difficult to assess really well, particularly from a screener standpoint, and certainly to quantify it. But I think it's important to look at the atrial septum and look at flow across the atrial septum. But I personally don't find I don't think that's going to be, I think it's too difficult to distinguish normal from abnormal for that to be a really important part of the diagnosis. But I think it's very important. And then you had one other thing I think you mentioned.
Yeah, the diastolic flow in the distal arch and the branching pattern. If you have an increased distance between your second and your third branch of your arch.
Thank you. I should have mentioned, I do think that's relevant. If you have an increased distance between the left common carotid and the left subclavian, that is kind of shown to be a sign. So you should look for that. Some people can quantify it. I don't really quantify it, but it's just something to, in your mind's eye, as part of the overall assessment of a risk factor. If there is an increased distance, that should be something you see. And then in terms of the flow pattern, I mentioned, I think I had 1 or 2 slides showing flow pattern can be abnormal. But we've all seen cases where we see abnormal flow distally and turns out to be normal. And that means we just didn't really understand fully the physiology. And we need people like yourself, Sally, and others to help us, teach us what the meaning is. Sometimes we're all learning, but certainly you want to look with color when you get a sagittal view. If we're doing a fetal echo, we should get a good sagittal view, look at the flow pattern. And if it's abnormal, if there's any significant retrograde flow in the distal arch, we need to try to identify that, then figure out what we think that means. But then finally, my last comment is, it is the counseling that we do is really important, not just the what we do with the baby after birth, but how we manage, how we counsel the mother before birth so that we don't because it is incumbent upon us all to have a lot of false positive cohorts. That's going to happen. I'd much rather false positives than false negatives and missing it. And it's a matter of that's the art of medicine, how we talk to mothers so that we make sure we don't miss cohort, and yet we don't unnecessarily cause a lot of distress, and we don't take the baby away prematurely after birth if we don't need to.
What about the isthmus measurement? Where do you measure it, and do you go for these chords, or you compare the isthmus to the left common carotid or left subclavian diameter? What is your
Right. Yeah, there are, like Wayne pointed out, there's so many studies, there's so many measurements. The first thing is you need to get good image quality that's reproducible. If you're going to do any measurement, it better be reproducible in your own hands at least. And most of the time that I've seen studies, I've looked at others, the image quality is not that great. So I don't know how you can measure it reproducibly. But then if you can get really good pictures, then I think it's up to, some people prefer the 3-vessel view to measure. Some people prefer I'd prefer the sagittal aortic arch measurement to measure it. But you just want to be, as Sally talked about in her study, if we're going to do any quantitative measurements, you need to be consistent internally and look at things in the same way each time. Ideally, it's going to be reproducible by others, but certainly internally it needs to be reproducible.
The word, when you said retrograde flow in the descending aorta, I think I would add, provided it's not an IUGR.
Yeah.
Yeah, so these findings, that's part of it, is that the flow pattern, disturbances in flow pattern in the aortic arch can reflect lots of processes. Coarctation is one of them, but there's many other abnormalities that can be occurring. Same thing at the level of the foramen that affect physiology beyond coarctation. That's part of why it's so challenging and that's why I think part of why we have a lot of false positives, but it's not the whole reason. It's also just that we are good at identifying risk factors for cohort, but they're not that specific.
Dr. Silverman, do you have anything to say? Dr.
Yeah,
Silverman?
he had his hand up.
Oh, okay. I have a question from Bree Muller from Raj.
I think that it's time now that we move on, because
okay, just last question from Bree Muller from Raj. Yeah, thank you. Our center has more fetal premature closure of PFO mimicking coarctation in recent years. Any thoughts of this from Raj? Any answers?
Well, this is what Adam was alluding to. This is exactly what he was saying.
Mm-hmm.
Yeah.
So
it is very. Yeah. Let me just say, Rima, I agree, and I think it's an area of looking. If those of you watching this do not routinely look at the foraminal valley and look at the flow and look at what the septum itself looks like, it's something that we should all start doing and looking at more carefully, because it can be a very important area that could give us insights into why the left side may be looking small, different from anatomic arch obstruction.
So the message is, if you see a premature closure of the foraminal valley, what would you do? You do an oxygen test, maternal hypoxygenation test, or just follow the patient, or bring back the patient? What would you do? Because it says mimicking coarctation, so it's not a coarctation. Yeah, and when you do the maternal hypoxygenation test, you look for the pulmonary vascular resistance and with oxygen, without oxygen, right, in the pulmonary arteries.
I'll say what we would just observe and counsel the mother that I think this is going to be, everything's going to normalize after birth, most likely, but we'll look to be sure. But we suspect everything's going to be fine. But we here at UCLA have not been doing anything beyond that. I'm curious what Sally or Adam or others, what your thoughts are.
I follow them up and I check that the right ventricle does not fail, and otherwise let them deliver normally and with a good prognosis generally.
So basically, if you see the foraminal valley is not moving, the flap and all that, and the flow is slightly restricted, but the arch looks okay, you wouldn't bother, right?
Well, we definitely follow them up, and because they may be at risk for heart failure.
Follow them up, you bring them, you deliver in a tertiary center, or let them deliver in their hospitals and bring them for a postnatal echo. What would you do?
It depends. I think when it is like late second trimester, for example, in our center, in several cases, we were trying, like hyperoxygenation therapy for that, to have this ventricle filled, because still, and this is the left ventricle issue, you have a smallish mitral annulus, so they tend to develop some degree of stenosis. Occasionally they have diastolic dysfunction, so maybe it's better to treat. In 2 cases, certainly, they needed the aortic arch repair. And in 1 case, 1 patient has AFR for mitral stenosis. It looked like exactly like a coarctation from like mid-2nd trimester with smallish left ventricle and smallish aortic arch. So it required heart surgery, but also it has all other kinds of problems related to this borderline ventricle thing. So it depends. When it is late pregnancy, like 34th week or 35th week, and they are referred for ventricular imbalance, and you can see that there is bulging foramen ovale flap, and there is a restriction, and it responds to oxygen, then of course this is low risk. But when it lasts longer, it may be a higher risk, because not only of the arch, but also of other issues. This is how
You talk about the 10 minutes hyperoxygenation, or how long? The maternal hyperoxygenation test, 10 minutes? Yeah.
usually it's like 15-20 minutes.
Okay. So it's the short one. Yeah.
I prefer to scan on oxygen to see how it changes in time. Like every
Right.
5 minutes, I reinvestigate everything.
And this ventricular discrepancy, I think it's very important, because near delivery, the RV will be bigger, right? It's a dominant ventricle. So you said I can get them at late trimester for ventricular discrepancy. So is it more than what the ratio is really bad, or how? Because how would this be of value? Because we know that the RV is going to be bigger than the LV after 32, 33 weeks, part of the natural progression of the growth.
We always check the dimensions, and I think my personal threshold will be like 0.8. Below
the ratio.
0.8,
The ratio.
yeah, of the LV minor diameter. I will look for it more carefully.
Thank you so much. I think, as Dr. Silverman said, we have to move to our last speaker, but not least, we're very happy to have Adam Kolensik from Poland, Department of Perinatal Cardiology and Congenital Anomalies, Center of Postgraduate Medical Education. He's going to talk to us about beautiful and a very tough topic about the systemic venous return. Adam is interested in morphology, and so probably we're going to enjoy seeing lots of anatomy and pictures of value. Thank you.
Thank you so much, Rima. This is just a short presentation of what I love the most in anatomy. It means the veins. The veins are very special. Usually they follow arteries, but some of them don't. They're absolutely unpredictable. They find their ways. When there is an obstruction, they will find a way to bypass it. And we are in very, very special privileged position in the fetal scanning, that we can see almost the entire venous system in terms of course, the large veins. As you probably remember, the main veins of the embryo drain to the part of the heart tube called the sinus venosus, that has two horns, and each of them receives the umbilical vein, the vitelline vein, and the common cardinal vein. And after several transformations, the position of the sinus venosus becomes more ventricle and more vertical. The right common cardinal vein becomes our superior vena cava. The vitelline vein on the right side becomes the inferior vena cava, its supradiaphragmatic segment, and the entire left horn becomes our coronary sinus. So it means that when we have the left superior vena cava, it drains to the coronary sinus. When the coronary sinus is unroofed, it drains to the left atrium of the heart, of course, in the normal segmental settings. So usually in the specimens, we see something like this. There is superior vena cava on the right, and there is right brachiocephalic vein and left brachiocephalic vein. Some people call them innominate, although these are huge veins. I think they should have a name, and this is the brachiocephalic vein. The left brachiocephalic vein is running in front of the head and neck branches of the aortic arch. So this is what it looks like normally, but occasionally we can see something like this. It means that there are two superior vena cava. One is on the right side and the other one is on the left side. And there may be some kind of connecting veins that resembles the brachiocephalic vein, but I think most commonly there is no connecting vein between them. So they drain absolutely separately. And this is exactly what we can see in the fetal scan. Usually in 4-chamber view, what is visualized as the first is the dilated coronary sinus. There is a circle between the left atrium and the left ventricle, and this is the reason for referral. But of course, there are some other conditions that are important to exclude, like abnormal pulmonary venous return. So we always look at it in several sections. And this is again about this all visualization part. So this is my favorite view. I always want to see the left superior vena cava draining to the coronary sinus that opens to the right atrium of the heart in this kind of frontal view. And of course, it's good to see the mediastinal views when you can see the right and left superior vena cava separately. And what's very important, I think, is to assess the direction of flow in this vessel, because when it flows up, it means that maybe it is a vertical vein. So you should check on the pulmonary venous return. When it flows downwards to the coronary sinus, you can also see it, and it's perfectly visible in this scan. So in this case, there is a huge left superior vena cava. As you can see, the coronary sinus is dilated, and you can also see it in the frontal views like this. And when you take a look at the next image, and this is a very similar case, the mediastinal view, this is kind of tricky. This patient came to us with diagnosis of right aortic arch, right ductus arteriosus, because the superior vena cava is exactly on the same side. Of course, the first important thing is to take a look at the sides of the fetus. Whatever method you use, it always should be done, because in this case, this is the left side of the fetus, and this is just the superior vena cava on the left side. That is the only superior vena cava of this patient, and it drains to the coronary sinus that perfectly opens to the right atrium of the heart. So in the end, the blood from the upper parts of the body flows where it should. But there are some issues. The topic is it variation or is it anomaly? It's questionable, because when there are no other conditions that we should check on, basically this is a kind of variation, because the blood reaches its destination. But let's imagine that in couple of years, this patient requires the central catheter or the pacemaker. It becomes a very, very important message, because you will never reach the right atrium of the heart and right ventricle normally in such person. So certainly it always should be emphasized that there is some other kind of anatomy, and parents should be aware of it, and it should be a part of the patient's history. And I think that we had some situations, some conditions when people forgot about it, because this was considered like unimportant. So we should keep it in mind. So in the fetal scans, of course, we see 4 vessels in 3 vessel view, as here. we can see the dilated coronary sinus. It's good to check if it is really left superior vena cava. In complex anomalies, occasionally, especially in complex anomalies, it drains to the left atrium, which means that the coronary sinus unroofing. We should remember that it can be the only superior vena cava in this patient, and this issue of coarctation ventricular imbalance is again questionable because there are also some papers that state that there is no correlation between LSVC and the coarctation of aorta. We always check routinely in the third trimester if there is imbalance, and we reevaluate the aortic arch, and we always scan them after birth for coarctation, just to be on the safe side. So I think this is something that Mark already emphasized before. This is a very interesting case that I also want to show you. This patient was referred to us because of hydrothorax, and what we found was the left superior vena cava stenosis, and you can see that there was a gradient here. In this stenosis, it was like up to 15 millimeters mercury. This stenotic segment was quite tight at the right atrium, and there were collateral vessels. This collateral vessel was part of the azygous vein system that ran behind the aorta, and it was stenotic in this area. So that's why there was a gradient, because the same gradient could be registered exactly in the same site. So there was high pressure in the upper part of the body. Most likely it affected also the thoracic duct, and that's why the hydrothorax was present, because of impaired lymphatic circulation. Nevertheless, the child was asymptomatic after birth, and we observed it for some time. The gradient was more than 20 millimeters of mercury at certain time, and this child was operated on because there was no way to balloon the stenotic region. There's like very, very rigid ring around the orifice of the superior vena cava, just to prevent the consequences of high venous pressure in the upper part of the body and in the brain. The surgeons got rid of this stenosis. Occasionally, there is no superior vena cava visible. It is atretic or absent. I don't know if it is really the agenesis, really, because this is the remnants of the common cardinal vein. This is a very substantial basic vein of the embryo. So most likely, maybe it became stenotic and then it's just disappeared. There was a collateral pathway through the azygous vein system that drained below the diaphragm to the inferior vena cava, and there was another problem. The problem was that this child, after birth, required the liver transplantation. And again, is it the variation, or is it the abnormality? Then I don't know what malformation. Then what should we call it? I think in a normal setting, the blood from the upper part of the body flows to the right atrium of the heart. So maybe there are no symptoms. But in this setting, when this child required the liver transplant, when you clamp the inferior vena cava, you clamp the entire venous system in this person. So this transplant was done together with cardiac surgeons, and they put this child on ECMO to take the blood from the systemic veins and pump it to the arterial system to bypass the heart, not like a regular bypass that usually is done between the femoral and jugular veins, because there was, of course, no reason to do this. or it won't work in this case. What I think is the most interesting part of the systemic venous system for fetus is the portal or umbilical portal circulation, because the liver, when it develops, it interrupts the course of both vital and both umbilical veins. It creates new connections between them. One of these connections, the biggest one, is called the ductus venosus. So this is the vessel that is formed de novo. Basically, I like this schematic picture very much, because it shows that there are two umbilical veins in the beginning, and they are both interrupted. There are two vitelline veins, and they create 3 or 4 levels of connections, as you can see here. And these connections transform together with the left umbilical vein into the portal system. So in the end, you have the portal vein that drains to the liver. It flows through the liver capillaries, and then the blood is collected by the veins and flows toward the heart. And of course, this new connection in the form of ductus venosus is formed. So this is the final, this is the stage of the development when this asymmetry appears, and this is the final result of this development, that we have a normal portal system and the ligaments formed of the umbilical vein and the ductus venosus. I'd like you to see this image. This is a corrosion cast of the fetal liver. So this is the umbilical vein right here. This is the portal sinus, the ductus venosus with this narrowing in the proximal part and dilation in the distal part. And this is the portal vein of the fetus, the true portal vein that runs behind the stomach, behind the pancreas, and becomes when it's formed when the superior mesenteric vein and the splenic vein fuses. So look at the angle between the right branch of the portal vein and the portal vein, the stem of the portal vein. It is unable to perfuse the left lobe of the liver at all. This blood from the guts, it flows only to the right lobe of the liver. It means that the left lobe of the liver and most likely also the right lobe receive the most oxygenated, the best oxygenated blood in the fetal circulation. So the liver is in a very, very special position. So the role of the ductus venosus is to accelerate the blood flow and make it hit the valve of the foramen ovale, open it, and go to the left atrium of the heart. So as you look at this scan, you can even see that there is a track for this blood formed of the valve of inferior vena cava, the eustachian valve, and the foramen ovale flap. So this is how the blood from the ductus venosus that is accelerated reaches the left atrium. And there's a very, very clear pathway for this. So we have numerous possible options of abnormal or alternative development of the umbilical and portal systems. And this is one of the examples that is in most of cases absolutely benign. It is persistent right umbilical vein. Quite often our patients are referred because of that. Usually we can't find anything special in this patient. There is also not a great correlation between this persistent right umbilical vein and other pathologies, extracardiac anomalies. It is a little bit different when there are two umbilical veins. Some authors state that these fetuses should be screened for extracardiac anomalies, but when there is just right, usually it is a benign lesion. I think this is the image that we should all look at. This is one of our patients. You can see the umbilical catheter inserted and the contrast injected, and it flows to the liver and nowhere else. I think of all these, let's say, benign lesions that should be considered as the variation, but also in some conditions, important source of the failure in our treatment is the absence of ductus venosus. The absence of ductus venosus with normal portal system, that's I think is quite common. In this case, this is right isomeric patient, and that's why it required the umbilical catheter. But what we always state in our reports, in cases of any kind of hepatic circulation abnormalities, is that you are not allowed to insert the umbilical catheter, because you never know what will happen to it, where it will go to, where you will administer your drugs. So I think this is important. It's not important that this is a benign lesion. The important message for neonatologists is that this umbilical vein is something you just can't cannulate because it won't work. There is no ductus venosus to reach the right atrium of the heart. Everything will go through the liver. But the spectrum of what people call the absent ductus venosus is a little bit wider, because some authors include abnormal terminations of the ductus venosus and abnormal terminations of umbilical vein into it. In this case, it's rather the ductus venosus that is draining low, and this is classified as such, but by some authors. You can see the acceleration here, and this acceleration protects the portal circulation. The intrahepatic branches of the portal vein in such cases are developed, and they can be absolutely normal after birth. So usually there is no volume overload of the right ventricle of the heart, so there is no cardiomegaly in such cases, or that this is very, very limited, and usually it closes after birth. So it's rare to get a portal systemic shunt in such setting. In this case, the heart is much bigger, and this is the abnormal termination of the umbilical vein to the right atrium of the heart that may be a substrate for aberrant malformation after birth. And in this case, you can see that the wide umbilical vein connects to the inferior vena cava, and this is what we found after birth. This is an injection through the umbilical vein, and this vessel is this abnormal connection to the right atrium of the heart and inferior vena cava. So we balloon interrogated it, and there are no branches of the portal vein normally developed in this case. Nevertheless, we decided to close it with an implant, and some residual shunt was present for some time. We kept this baby on heparins, and the portal circulation was restored. The same here in this case, where you can see a wide umbilical vein draining straight into the right atrium of the heart. We always assess the intrahepatic branching of the portal veins. It's very important to look at it. In the fetal scans, we have this opportunity to see all the vessels. We can track them with our Dopplers, and this is high-resolution power Doppler that is available in our system. You can see the splenic vein, the trunk of the portal vein. You can see how it enters the liver and how it gives off the branches. So you can assess the risk for this child. And in this case, again, the balloon interrogation, test occlusion, and you can see these branches that are hypoplastic, and we close it with the device. And the portal circulation was restored. Of course, when there is no volume overload and there is no, this is asymptomatic, there is no hyperammonemia, the hepatic enzymes are normal or close to normal, we wait. We always wait because most of such shunts have tendency to close, or we can close them later when the child is bigger. And I think it should be done before the 2nd year of age. We always should be mindful of the risk of development of the pulmonary hypertension in such patients, for example. So we look after them. But when the heart is as big as here, and we know that that there is a pulmonary overflow, and there are clear indications to close the shunt, we are closing it in newborns or infants. So again, this is a very important part of I think the fetal scan, to take a look at other vessels too. Occasionally, you can find some other portosystemic shunts, like here, a portosystemic shunt through the inferior mesenteric vein to the iliac vein in this fetus, with reversed blood flow in the portal vein and splenic vein that you can see here in blue behind the stomach. There was normal ductus venosus developed in this case, but this shunt that was abnormal created the hypoplasia of the portal system. Again, the problem after birth was that someone inserted the umbilical catheter, so it resulted in portal vein thrombosis with this reversed blood flow. So I emphasize it again, don't do this in case of the portal system anomalies. But some people can survive it, and this is the case after 8 years. This child most likely has something like this one before, and had bleeding hemorrhoids since 1st year of age. There was reverse blood flow in this dilated inferior mesenteric veins, and we had to close these varicose veins. And now we are trying to rehabilitate this portal system. So it may persist later on, and be diagnosed later in life. I don't want to talk more about development of the inferior vena cava, because quite often we can see the duplications and minor, let's say, malformations or variations like this. And of course, for the inferior vena cava, what's the most important for us diagnostically is the interruption. It means the lack of the retrohepatic segment of the inferior vena cava. That is quite often associated, or mostly associated, with left isomerism. Even when there are no associated lesions, the heart looks like it's almost normal. Maybe there is some slower heart rate. Maybe it looks like there is something wrong with the sinoatrial node. Maybe this heart rhythm originates somewhere else. But when we look at the family of this patient, occasionally we can find that it's repeating, and maybe someone had a congenital malformation of the heart in the past. So it may be like a form of the left isomerism that is just showing in this way, that there is only the interrupted IVC with no other visible anomalies. It's always important to take a look at the liver. We had the case with the interruption of the IVC and portal and biliary tract atresia. So I think this is this could be important, not only let's say anatomical variation. And I think that I will stop now. And thank you very much for your attention. This is just to show you the same anomaly in the fetal scan. So this is usually what you can see in the mediastinal. Looks like there are two veins in the posterior mediastinum, and of course parallel veins in the posterior mediastinum at the frontal. So thank you very much for your attention.
Thank you so much, Alan. Beautiful and very informative talk. We open the floor for discussion. And Sally, I'm not sure, Dr. Silverman, are you still with us? Sally, do you have any questions?
Still here. Yeah, I think that was an amazing talk. Thank you very much, Adam. I wanted to ask you if you could explain briefly the difference between a type 1 and type 2 Abernathy malformation.
Yes, I think I can go back to my slides to show you this on the picture, because it's here. So this is always subject to debates, and people usually have problems with classifying type 1 and type 2. Basically, in type 1 should be total agenesis of the portal venous system that virtually doesn't exist. It exists rather in type 1A, when there is no confluence of superior mesenteric and splenic veins, because in such setting there is no true portal vein stem. So this is something that results in agenesis of the portal venous system in the liver. But when there is a confluence of superior mesenteric and splenic veins, usually there are tiny branches that may be trained to become the fully functional portal system. And there are beautiful cases shown usually by Elkanan Bruckheimer from Israel that treats a lot of babies like this. He creates like he closes these shunts partially, allows for some blood flow, creates some kinds of banding of this connection, and the portal system develops. And in type 2, there should be a partial agenesis of portal venous system, and there are two variants. Congenital variant is basically what I was showing. So there are tiny branches of the portal system that require some training. When you close these portal systemic shunt, they develop in time. Usually we leave these children on heparin for a longer time, like we give them Clexane or other kind of low molecular weight heparins, to have some shunt across the implants, for example, to let the blood flow, and they develop the portal system. In a quiet variant, this is occasionally the shunt that develops after portal vein thrombosis, for example. So you have the connections between the portal system and the renal veins, or the retroperitoneal venous system, like lumbar veins or other or iliac veins. So it depends on how it forms. And again, the result is the same: massive portal systemic shunt. So I think this is it. The most problematic type is 1B, because occasionally you diagnose the agenesis, but in fact, only on balloon interrogation you can confirm that, because usually there are those tiny branches.
Thank you very much, Adam.
Well, Adam, so what does this mean in terms of antenatal diagnosis? What is the value of that?
There is a huge value, because first of all, you know that it exists. So most of the patients are referred to us because of heart failure or cardiomegaly, and we are the ones who diagnose this condition. So the other thing is that we can look after these babies, we don't miss them. So we occasionally have the patients, like adolescent patients, with hyperammonemia for a long time. So they have all associated problems, and we close the portal systemic shunts to get rid of it. We can also differentiate between the liver disease and the vascular liver disease, like the portal systemic shunt. For example, maybe Down syndrome patients are a good example. We had a couple of them. In prenatal scans, they had a perfect ductus venosus. After birth, they diagnosed the portal systemic shunts, and they were the neonatologists were trying to diagnose Abnormalities syndrome, but it was not the case. This was just a portal hypertension in a child with the ductus venosus that didn't close. So it was used like a bypass for the portal system. So you could see that very, very high levels of liver enzymes. There was a huge hyperimmunemia. So there was another reason for that. And based on our prenatal scans, we can say, no, this circulation was perfectly normal. This is not an issue with a portal systemic shunt. This is a sick liver. Sometimes it's very difficult to differentiate in the newborn.
With absent ductus venosus, do you expect heart failure? And the question goes also to Dr. Silverman, because it's a spectrum, right? Not all absent ductus venosus will go into heart failure.
True.
All right. And you said something very important as take-home message. When you show the azygos, you said this is isomeric heart regardless of the internal anatomy of the heart. Is this correct, Adam?
No, not exactly. I think in some of the cases, maybe even most of the cases, you should consider this, that not all the isomeric cases show the whole spectrum of the disease. Occasionally, there are benign forms. When you look at the appendages, maybe you will see two lefts. When you look at the bronchi, maybe you can.
No, I mean, I had a case where they asked for termination just because of the azygos, and I think the discussion was, and Dr. Silverman, please back me up. If just the azygos is there, is this a left atrial isomerism?
No.
No, it doesn't have to be. And even if it is, so when you have.
What?
Yes, so what? When you have two left bronchi, okay, you can live with that. When you have two left atrial appendages that look the same, who looks at atrial appendages? It's maybe you later in life, in this person's 50s or 60s, someone will be very, very happy to put two implants instead of one into this left atrial appendages because they are too close. But this is a benign lesion for this person. But for example, for the genetic counseling, it is important because when you track these families back, occasionally you can see that there were cases of the heart disease. So
but would you label this as left atrial isomerism in your report? As it is interrupted IVP,
I will keep it in mind.
Okay.
You will not
do any genetic.
I just know that it may be a left isomerism, but it's nothing to.
I'd like to thank you all for staying late, and many thanks to Sally, Adam, and Dr. Silverman. And the whole episode will be on the YouTube under Congenital Heart Anatomy Fetal Series. And we'll see you in a month's time. Thank you so much. And I think good night or good morning, wherever you are.
Thank you.
Thank you very much, everybody. You all did a wonderful job and we all learned a lot. Thank you so much.
Bye-bye.